This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on cervical foraminotomy. Foraminotomy means opening up the foramen. The foramen is the hole where the nerve comes out. So if somebody has a pinched nerve from a herniated disc or from foraminal stenosis, which means narrowing of the hole where the nerve comes out, so they've got this nerve pain which can go down the arm, from the neck, down the arm. Depending on where it goes in the arm tells us which nerve is the problem. The C6 nerve goes to your thumb, 7 goes to your middle finger, 8 to your pinky, C5 goes up into your shoulder, and then we do a motor exam. We check the strength and sensation of the arm, and that tells us what nerve is being involved from the history and the physical exam. Then we look at the MRI and maybe a CT scan and x-rays and determine where the nerve is being pinched. And if everything matches up and we really know what's causing the pain, the cervical foraminotomy is a great surgery for opening the hole for the nerve and taking a disc herniation out to take the pressure off the nerve. And either one of those can be true. Sometimes people have foraminal stenosis, which generally is overgrowth of the facet joint. For every disc you have in the front, you have 2 facet joints in the back. That's where the motion occurs in the back. Those joints can get arthritis and degeneration, and they can overgrow. They can get bone spurs that overgrow from the joint, which then crowd the room for the nerve. And the foramen means window in Latin. So the windows are the holes where the nerves come out of the spine. Those are the foramen. And stenosis means narrowing or restriction. So foraminal stenosis means narrowing or restriction of those windows. The holes where the nerves are coming out are narrowed. It's either from the facet joint being overgrown due to the arthritis, or the disc bulging up or herniated from the front, putting pressure on the nerve. And the foraminotomy is basically a microscopic surgery. It's very minimally invasive, where we basically sneak in, make more room for the nerve. The foraminotomy means open up the foramen, which means removing some of the facet joint and the bone spurs to open up the hole. And then if there's a disc herniation, we can take it out through the hole we've made. In our experience, foraminotomies work best if people really have distinct nerve pain. For instance, a positive Sperling's maneuver, which means you turn your head to that side of the pain, tilt your head back, we push on your head. If that shoots pain down the arm, it means the nerve is being actively irritated and compressed in that hole. So if we go in and do the surgery and just open up the hole, it generally helps people. Another good sign is if somebody walks in our office with their arm on top of their head. If you put your arm on top of your head, you relax the nerve. And so people whose nerve is under tension and in pain, they walk in with their hand on top of their head because it's relaxing the nerve. That's when these foraminotomy surgeries generally work really well. It's a pretty obvious sign. Somebody walks in, hand on top of their head, I'm already thinking I know what can help them. So after we've determined what's the source of the pain and if the person has failed non-operative treatment and it looks like we're going to do surgery, there's 3 basic options in the neck. There's a fusion, there's an artificial disc replacement, and there's a foraminotomy to treat these nerve pain issues. The fusion's the most gold standard surgery, been done forever all around the world. The fusion does everything. Makes more room for the nerve, directly takes the pressure off the nerve, stops the motion, stops any residual irritability of the nerve, and stops any bone spurs from forming or regrowing. So the fusion's the number 1 surgery done all over the world for those reasons. Downside to the fusion is we're putting an implant in and it stops motion at that level, which puts more stress on the other levels, which may accelerate the natural wear and tear and degeneration of the other levels. So that's the downside to the fusion. Even though it treats that nerve most reliably than just about anything, there's a downside to it. Artificial disc replacement's a great surgery because it preserves motion, but by preserving motion, you can still have irritability of the nerve, especially if you have bone spurs coming off the facet joint. So the foraminotomy is actually going in from the back is really a third alternative, and it's a great surgery because number 1 is there's no implants. There's no fusion or artificial disc. We're not putting any metal, no bone, no implants. We're literally sneaking in with the microscope, making more room for the nerve, and that's it. It's a pretty straightforward, easy surgery. One of the benefits to the surgery is we're not doing a whole lot. We just make more room for the nerve and get in, get out. One of the downsides is we're not doing a whole lot. We make some more room for the nerve, but it won't necessarily treat that nerve permanently and forever. What we do in the surgery is pretty small. It's less than a 1-inch incision. It's in the back of the neck. We use an x-ray to tell us where to make the incision, right over the hole for the nerve. And then we go in with a microscope and we basically remove part of the joint. We work from the opposite side of the table, which allows us to undercut the joint. We want to save as much of the joint as possible. The facet joint is doing a job. It's providing stability and preserving motion. So we can't take out the whole joint. If you take out the whole joint, well, then you have to do a fusion. If you remove all the stability, you have to replace the stability with the fusion. And we're trying to avoid a fusion. So we can't remove all of the facet joint. Studies have shown you can remove about 50% of the facet joint and still preserve stability because you have another facet joint on the opposite side and you have the disc in the front, and the disc provides most of the stability. So studies have shown you can take out about 50% of the joint and save the stability and do that surgery successfully. In our experience, 50% is more than we typically take. We've seen 3 professional football players that have had complications after foraminotomies. 2 of them got fractures and because when you remove some of the joint, you can weaken the inherent stability. And especially if you're going to go back to play football, which obviously is an extreme example. The people are out there hitting each other with their heads and getting hit in the head, and also it's a violent collision type of sport. But it showed us that, you can't remove too much of this joint. You have to preserve as much as possible. Now, that may have happened regardless. You may have only removed 10 or 20% of the facet joint. You play football and you get a facet joint or a lateral mass fracture. So it wasn't a result of the surgery necessarily, or it wasn't that the surgeon took too much joint. We've had football players with fractures in their neck who never had surgery beforehand. So it can happen regardless. It's a violent sport, and it can happen with other sports as well. Soccer with heading, with playing baseball, you slide head first. Basketball, if you fall and hit your head. So fractures can happen. It's a part of life and a part of traumatic events we see to humans, but basically, we want to save as much of that facet joint as possible because it preserves stability. So that's the limiting factor in the surgery, is we want to remove some of the medial aspect, the inside of the joint, to open up the hole for the nerve, but we don't want to take too much because we want to preserve the stability. And we've had excellent success with this surgery in a lot of professional athletes, football players, hockey players, baseball players. There was a study that came out recently that looked at reoperation rates after cervical foraminotomies in professional athletes, and it showed about a 40 to 45% reoperation rate after a foraminotomy from having different types of complications or residual issues. That is higher than our experience for sure, and almost every surgeon you talk to across the country, that's higher than what most people's experience are. Part of that is just the limitation of the study. It was based on internet data, and so we certainly don't think it's 40 to 45%. But it shows you that reoperations can have to happen because of fractures or of a recurrence of issues. And part of the reason why the issues can recur is because we're limited in how much of that joint we can take out, and the problem can come back. The overgrowth can occur again. You can have a bone spur in the front coming off the disc that's still irritating the nerve. So the foraminotomy is a great surgery, very minimally invasive, microscopic, quick recovery, but it's also limited in what it can accomplish. The real benefits to the surgery is that there's almost no muscle dissection that's done with the surgery. It's less than a 1-inch incision. We pull the muscle back, make more room for the nerve, close everything down. Most people have some soreness in their neck for 2 to 3 days. A lot of people don't even really have any pain. You can get some muscle spasms after the surgery, just like any surgery on the neck, where the muscles get tight and lock into place to prevent any motion. That's usually treatable with muscle relaxant medication or narcotic medication. Most people don't really take narcotics after the surgery, maybe for 2 weeks at most. It's very rare that it's any longer after that. But sometimes it does happen. There's always potential issues with any person. Anti-inflammatory medication, Advil, Aleve, Naproxen are all good after the surgery. If somebody's still having pretty significant residual nerve pain, then we'll treat them with steroids like prednisone. And a short course of prednisone for 5 to 7 days is usually very safe in almost everybody. The surgery itself takes about 45 minutes to an hour. It depends on how bad the pathology is, obviously, and it depends on if we're taking a disc herniation out. If somebody has a soft piece of disc that's in that foramen, then we can take it out from the same approach, and that usually adds 15 to 20 minutes to the surgery. There's a vascular leash. There's blood vessels in the area that typically have to be coagulated in order to get the disc piece out. But typically these disc herniations are under pressure. So if we do the foraminotomy and make some room and then get rid of the blood vessels in the area, typically the disc presents itself and is pretty easy to take out. There's always a risk with any surgery, the risk of nerve damage, getting numbness, weakness, pain from this surgery is rare, but it can always happen. There's always a risk of an anesthetic, stroke, heart attack, death, infection, spinal fluid leak. But overall, this is a very safe, reproducible surgery that under the microscope, you're basically able to see everything you need to see. This surgery is done as an outpatient, or people stay overnight, and a lot of that depends on when the surgery is done and if they're from out of town. People who come from across the country, we generally keep overnight in the hospital. People who live nearby typically go home the same day. And the dressing we put on there, we put on a sterile dressing in the operating room. So we prefer for people just to leave that dressing on for 2 weeks even. If you have any questions, don't change it, just leave it on. Typically, if there's any irritation or starting to bother you, you can take it off after 7 days. So the wound itself, we actually close with absorbable sutures, which are buried, and there's nothing to take out. They just dissolve after a couple months. Then we put glue on top of the wound, and then we put steri strips on top of that, and then the dressing. So there's quadruple reinforced dressing. And so if the dressing gets wet or emaciated or dirty, you can always change it. It's not that big of a deal, but we prefer just to keep it on for at least 7 days. If you want to shower where you can take waterproof dressings and put those on top, and then after the shower, just take the waterproof dressings off and leave the surgical dressing on. For the first 2 weeks after the surgery, I tell people to take 2 weeks off of your life. Don't plan on doing anything. Don't have any meetings, appointments. Don't plan on going anywhere. Just take 2 weeks off of your life. Let your body heal. Let the muscles settle down. Let that neuromuscular control come back. Take some pain medication, relax, let everything heal. Now, most people can go back to work after 5 to 7 days realistically, but if you have 2 weeks off, well, then you have some freedom. And if you're doing well after 3 to 5 days, fine, go back to work. But at least have that 2 week of free time where you don't have to drive and nothing's really expected of you. We give everybody a neck collar, a neck brace to wear. We generally want you to wear that for 2 weeks, especially when you're up and walking around and if you're out of the house, because it gives the muscles a break. They don't have to support all the weight of your head. It can give them a break, let the wound heal, and decrease people from having pain. So don't plan on driving for 2 weeks. You can ride around. Somebody else can drive you. You can take Uber. You can go out to eat. But plan on taking 2 weeks off where you really can just do whatever you want to do and nobody's going to bother you. We see people back 2 weeks after the surgery. At that time, we check the wound and we see how the patient's doing. And then we typically plan on starting the physical therapy at that time. Typically, we start physical therapy 4 to 6 weeks after the surgery. This is not a very invasive surgery. We can usually start the physical therapy at 4 weeks so long as the pain is minimal. And the physical therapy starts with 2 basic components. One is back strengthening. The second one is neck strengthening. We start with your back, your lumbar spine, trunk stabilization exercises. We want you to get your abdominal and your back muscles locked in to work in a coordinated fashion to support the rest of your body. It all starts with the foundation. You got to build up that core strength first. Then the second component, the neck strengthening, is really chest out posture exercises. We don't work on the head and neck itself. Some people do these resistive exercises where you're pushing up against somebody's hand or putting weight on your head. We don't really want to disturb the neck and the neck muscles. We want to work on all the muscles around it to keep the stress off the neck. And so if you stick your chest out, let your shoulders fall back, it brings your head back over the rest of your body. And so scapula stabilization exercises supports your head in a better position. So our whole program is basically spine postural exercises of your back and your neck to better support your head and to support your neck without a lot of specific neck strengthening. We can get to that, especially for football players and other sports. They got to build up big necks. You can get to that later. But right after the surgery, we just want to work on more spine postural exercises to protect your neck and to put it in a better position. Return to activities after the surgery. Most people are back to their normal life after 2 weeks. As far as going back to sports, it's typically about 3 to 4 months. It typically takes your body about 6 weeks to heal from a surgery and at least 6 weeks to do all the rehab to be ready to play in a professional sport. We've had people go back sooner than that. We've had people take even longer. But average 3 to 4 months, which is about half the time as it takes for a fusion. And so the other benefit of the foraminotomy is a faster recovery, faster return to play. And because we're not fusing it, less risk for the other levels. But as we mentioned, the downside of the foraminotomy, there's always a chance you can get a recurrence of the symptoms. The facet joint can re-overgrow, the nerve can get irritated, the disc can herniate more. And basically our backup plan after a foraminotomy, if it doesn't work or if people have issues down the road, is a fusion. And the fusion just kind of obliterates a segment. It gets rid of the whole disc, it stops the motion of the facet joints, it takes all the pressure off the nerve, and that's always a good backup plan. And after doing a foraminotomy, doing the fusion is not any more risky. And so a lot of times we spend time with the patient to explain to them the whole situation. Foraminotomy is a great surgery. It's shorter, it's faster, better recovery. People get back to their sports faster. No risk for other levels being stressed more because of the foraminotomy. But if it doesn't work, we can always do the fusion. And as long as the patient has a clear picture understanding of why we're going down this path and what's the positive and the negative, it's a great surgery we've had great success with. And if we can be of help in the future in any way, please let us know. Thank you.